before getting into that, we should know what is actually CLABSI, that you all will be knowing, and why it matters a lot, and what are all the impact happens in the healthcare because of the CLABSI. So today your learning outcomes would be, you will be knowing what is CLABSI care bundle and the importance, and you will be knowing about the evidence-based practices in the central line care, and you will be able to demonstrate the adherence to IPC during insertion and maintenance, and evaluate and improve the current practices what you currently have after the session, and you will be completely committing yourself to the Zero CLABSI as a realistic goal. So these are your learning objectives today. So what is real world impact of CLABSI? So if a CLABSI occurs, one of the healthcare associated infections, so if it occurs, what actually happens to the patient? Those are the people who are the sufferers in the healthcare system. So there will be an increased mortality rate, and they will be expecting the average length of stay. So that is going to increase. So they will be obviously end up in extended length of stay, that is hospital stay is increased. And third thing, if the length of stay is increased, they are going to pay from the pockets a huge than what they have planned. The cost is going to go ahead. So average stay for the patient with the CLABSI is like about 24 days. It's extended from the average length of stay. So if they don't get affected with the CLABSI, if all the practices are very appropriate, then they're going to discharge in 7 days of time. So this is all about the real world impact. So the study says like ICU CLABSI rate in Indian hospitals, that is out of 1,000 catheter days, 17 patients are getting affected, and each CLABSI, this is the cost involved for the CLABSI patients, it's like 30 lakhs actually.
No, it's not 30 lakhs.
It's actually 30,000.
Yeah, 30,000, but it is in a government hospital. The study was from a government hospital.
Okay.
So we really don't know what is it in a private hospital.
Yes.
I don't think there are any Indian studies yet.
Yes, thank you, sir. Thank you for pointing that. So this is a quick oath. So this is the one question. You can know, if all are using the users in the mobile phone, you can click onto that response. So what is your current ICU's average CLABSI rate? If you know, you can answer this. So this will give a lead to the like future slides. So if you're not able to answer, you can even drop your answers in the chat box.
Yeah, we have several answers saying less than 1 and 1 to 5.
Okay. 1 per 1,000, less than 1.
Yeah.
I think almost like less than 1. Less than 5, there is one response. Okay, 1 to 5. Okay. Less than 1. Okay. Okay. Thank you for all your responses. So CLABSI, it is like usually when we are considering that as a CLABSI for a patient who has a central line in situ. Like after 48 hours of insertion, it is considered to be, if the patient is developing infection, it's considered to be a CLABSI after 48 hours of insertion. So how we are going to diagnose? Two things. One is we'll be sending the patient blood for the blood culture positivity, and also if no other infection source, then it considered to be a CLABSI. Often all the healthcare, as we used to say, all the healthcare associated infections are preventable. Is similar to this, the CLABSI is also preventable with proper care. So what are all the causes of CLABSI? So you should know non-adherence to the hand hygiene. If you are not following the hand hygiene protocols properly, then there comes the cause for the CLABSI. And second thing, poor aseptic technique during insertion. Even though it is done in the bedside, we are not taking the patient to the operation theatre and performing the procedure. It's a sterile procedure. You have to follow all the strict aseptic technique during the insertion. Third thing, prolonged catheter use. The patient, you have to assess. That will be dealt in future by Dr. Pari. Like if the patient is like for the prolonged use, you should know actually the necessity of the catheter for the patient. And infrequent site inspection. Every time you go to the patient, you are doing some medication administration or routine assessments, you have to check for the site, and also improper hub disinfection. So you're handling, giving medication, you have to give the hub care. So for example, for hub care, you have to follow like 15 seconds, 30 strokes will be done. So those are the things, if you are lacking in all these factors, all 5 factors, this will be the major cause for the CLABSI. So here is your second question for your suggestions. Like, which of the following is the most common challenge in your setting? So we have discussed before like common causes of CLABSI, right? Depending on that, this question have been raised. What do you actually think which is the most common challenge in your setting? Whether it is hand hygiene compliance, aseptic technique insertion, or the other 4 reasons which is listed here. You can drop your answers in the chat box as you have done earlier. Your hand hygiene, hub cleaning, timely line removal. So option 1, 2, 4. Okay, done. And all of the above, yes. Hand hygiene, hub cleaning. Okay. I think all of the reasons are stated, doctor, in the chat box.
Yeah.
Yeah.
Yeah, I think almost all of them are quite relevant.
Yes.
We're not asking which is the most commonest.
Yes.
We said, which of the following, I mean, it is the most common. That's the question.
Yes.
You're asking which is the most common challenge.
Common challenge.
All are important.
Yes.
But which is the most common challenge? I think even in the poll, they pointed out, majority were talking about hand hygiene.
Hand hygiene. Here again, it comes, the maximum answers were about the hand hygiene.
Yeah.
Yeah. Okay. So let's move to the next thing. So what are all the best practices that prevent CLABSI, insertion and maintenance bundle?
Okay.
It's all yours, Dr. Pari.
Thank you so much. So before I start, I wanted to share with you this particular study. I think anybody who is working in the ICU or is involved with the care of a central line should be aware of this study. You will be knowing the reason why I am telling this. So this was a study from Michigan. It is known as the Michigan Keystone Study about CLABSI. It was done by a doctor called Peter Pronovost. So here is the, it is now it's become so popular, it is known as the Pronovost bundle. So the bundle is getting named after him. But this is so important. That is the reason why his name is before the bundle. So he did this bundle care in his hospital and reduced the CLABSI from 2.7 to 0. I mean, it is actually 0.7 was the exact percentage, but it was a remarkable achievement in having 0 CLABSI per 1,000 catheter days. And people, when he published it, people said, oh, maybe in one hospital this will be possible. But he did not rest with that. He collaborated with 18 ICUs in his region and did the study for another 6 months, giving the same bundle care. And in all the 6 hospitals, the same thing happened. So that is when people realized there's something there about it. And now this bundle is practiced all over in the USA and also in many parts of the world. And there is a hospital which has actually reported this bundle being implemented in their hospital with 89% reduction rate, which means almost like 90%, is again close to 0. Okay. So this is how this bundle works, and that is what we're going to highlight in this particular free webinar. And you will see that this bundle, next slide please. The components which he used in the the Pronovost bundle is only the insertion bundle. He didn't even bother about the other maintenance bundles and all those things. And there were 5 things which he focused on. One is hand hygiene, as we all know. The second is maximal barrier precautions. I'll explain to you what that maximal barrier precautions is. The third is chlorhexidine skin prep for the skin site. Fourth is selecting the optimal site and avoiding femoral. And fifth is reviewing of the necessity for the central line every day. So this is a simple, low-tech bundle. No technology is required. No money needs to be spent. Probably the only money needed to print a checklist. And nowadays you can have the checklist in your phone. Okay. So let me talk about each one of these because it is not what we think. There were subtle differences in how he implemented each one of this. The hand, as Stella pointed out, even though the central line is something which is done at the bedside, you are actually going through the skin into these one of the central veins. So it becomes a very critical procedure, and you need to follow all the sterile precautions which are done in the theater. So if you are aware of aseptic non-touch technique, this is classified under sterile technique, non-clean but clean technique. So because it is a sterile technique, the hand hygiene has to be done as you are doing for surgery. That means you need to scrub up to the elbow, not just use a rub for your hand. So you need to use soap and water, scrub up to the elbow as if you are going to the operating room. And the second is maximal barrier precautions. What do you mean by that? One is the gown you're wearing also should be like the theater gown, or you should wear the theater gown, fully gowned and gloved, not just wearing gloves alone, sterile gloves alone. Okay. So we are no. This is why this CLABSI rate is going up. Even though we know it is sterile, we are cutting corners by just doing just a hand rub, and we are cutting corners by just wearing a sterile glove. But he did not do that. He made his people scrub as if they were going for surgery up to the elbow, and he made them wear sterile surgical gowns. And he standardized the skin prep. It is not up to the preference of the individual. Everybody had to use chlorhexidine skin prep, and it is not because of his preference. Evidence shows that chlorhexidine works better than povidone iodine in any part of this skin. So that is what he used. And the fourth one was almost as much as possible, they avoided the femoral line. Even in the emergency, it was only done in the neck, not in the femoral, because again, there was enough evidence to prove that femoral lines cause more CLABSI than neck lines. And fifth, meticulously, the nurses and doctors, and they did the rounds, they had to go through this process of checklist asking if this line is necessary or not. And if it is not, it was removed immediately. So these were the 5 things he did. As you saw, it was not any technology or anything, just a simple checklist, making sure that things were available and done in the proper way. And what he did is he gave this checklist to the nurses and asked them to supervise the doctors who were putting the central line. You know what would have happened. So many of the doctors protested, saying that nurses are supervising, but he said, look, this is for the patient's sake. Please go through this and we will see. He was able to convince his juniors and his peers, and that is how he was able to achieve 0% CLABSI rate. Now, you tell me, if any of these things is not possible in your hospital, then we can accept a CLABSI rate more than 0. If any of you think that any one of this is not possible in your hospital, please raise your hands or put your comment in the comment box. Every one of them is doable, even in a very small primary healthcare center, right? So that is how basic it is. So this is the insertion bundle, and please remember that it is possible in every hospital to bring the CLABSI rate to 0. Okay, so that is the most important message for this webinar. Next slide. Because the rest are all add-ons after this, right? With this itself, we are achieving 0. And then what is the problem? So this is a typical scenario. 68-old man admitted ICU with septic shock. Everybody is in a hurry. So you don't want to wait. You place it in the femoral vein, the central venous place in the emergency. But after receiving the ICU also, the team plans to use it for vasopressor for the next few days because it has been put. So it's not, is it a good decision? No. We know by evidence that femoral lines cause CLABSI, and that should be removed as much as possible. So I know a lot of people have answered no, and it is true, right? So we don't want, even though no, in an emergency, okay, whatever is accessible has been done, but the sooner you remove it, you are going to reduce the CLABSI rate. Okay, so that is why this case scenario is important. Next slide. Now, the components of CLABSI bundle, again, I'm just going to emphasize aseptic access, daily site inspection, and again, additional things like changing the dressings when they are soiled or loose. And already Stella pointed out, scrub the hub. Whenever you're accessing the line, whether you're going to give an injection or drawing blood, you do the scrub the hub technique. This is taking an alcohol swab, putting on the hub of the central line, removing the cap, putting on the hub of the central cap and doing it like as if you're squeezing the orange juice, right? This motion 15 times or no for 15 seconds, sorry, 15 seconds is what it is there. So I think Sering Lamos asked the question. So you mean, sir, once patient shifted from EM to ICU setup should be preferably changed? Yes. So the longer you're going to keep the femoral line, the more the chances of the infection, CLABSI happening. So once the patient is stabilized and you have some breathing space, most hospitals will actually resite the line access to the neck. Next slide, please. Okay, some extra points on flushing and locking lines. So after giving any medication or any vasopressors, always flush the line after use with saline or heparinase saline. Positive pressure technique. Okay, don't try to withdraw and see if there is blood. Okay, always flush it, and if the flush goes freely and you just wait for some time, naturally the blood will come back to the catheter. So that is necessary. No need to put suction to your syringe. So prevent blood reflex. No, that is all. And so that several cannulas of the line don't get stained with the blood. And of course, you need to document that you have flushed and locked the lines. Next slide. So site inspection, again, this was emphasized earlier. Check daily for any redness or swelling. Keep the swellings and keep the dressings clean and dry. If the dressings are wet, lifted, or soiled, you have to report it and change it immediately. You cannot put the opaque elastoplast dressing for central line. You got to use a transparent dressing because that allows you to inspect the site. So this is another practice which we need to follow strictly is the central line dressing should be always transparent. Next slide. Okay, Stella, I think over to you.
Yes, sir. So what are the driving changes, like role of IPC team and the surveillance when it comes to the CLABSI?
Okay, so next slide, please. So just like any other HAI surveillance, CLABSI surveillance is also the responsibility of the infection prevention and control team. So though the ICU nurses or maybe the linked nurse in the ICU will collect the data, the surveillance and data tracking should be done by the IPC team. So the IPC team should work in collaboration with the linked nurse in the ICU to capture the CLABSI rate on a regular basis. Another important responsibility of the IPC team is staff education. As you will see, if you read the Pronovost paper, it is open access. Please, you can Google for Peter Pronovost CLABSI. You will get the paper. You will see that education was a major part in his success. So each and every new hospital he onboarded for this project, they went through a methodical process of telling them why those 5 steps were necessary and educating them on these things. So staff education is necessary. Similarly, auditing for the practice, whether they're following these 5 practices, following them properly. So they may say I'm doing hand hygiene, but actually are they doing a hand scrub like a surgical scrub? So this sort of audits need to be done. And then of course bundle compliance monitoring. And if you get any feedback or any concerns from the ICU or in the ward, then you need to take the corrective action and bring in a culture of accountability. We already spoke also in the polls about shared responsibility. So reduction of CLABSI is the responsibility of the whole team. And also the IPC team should inculcate this culture into the whole team. So that is the supervisory role the infection prevention and control team does. Next slide. So pitfalls, common pitfalls again from various studies, they have pointed out that these are the 4 common pitfalls in line care. One is you delay the dressing changes. You would have noticed it is a little bit soiled, you say, okay, let's change it the next shift. So don't do that. Change it properly. Poor documentation. Many times, even though things were done, they were not documented. So we don't know whether it is done or not. And the third most important, we keep emphasizing this, don't keep a line more than what is necessary. So there is a study which showed that for every additional day the CLABSI is in place, it goes up, the CLABSI rate goes up by 2%. Every day, extra day it is there, it goes up by 2%. So whenever is necessary, just remove it. And again, assuming that someone else checked. So you need to make sure that you go through the checklist yourself and don't assume that somebody did that. So these are the common pitfalls in line care. Next slide, please. So we wanted to ask you, did you observe any of these 4 pitfalls or anything more in your hospital? Can you tell that, put that in your in the comment box if there's anything more than these 4 which you noticed in your unit, and what are the practical steps you are taking to reduce it?
You can leave your answers in the chat box. Okay.
Yeah, Vidhi Talva says mere ticking the checklist without steps being followed is another pitfall. Yes, agreed. Hand hygiene.
And scrub the heart. Accidental removal of central line.
Yeah.
Yeah. Yes.
That's the other extreme, right?
Yes. So actually this is a question. I think later we can answer for it.
We'll take it up later, yeah.
Daily flushing. Can we use Curo caps for the ports which is CHC based? Chlorhexidine. Okay.
Chlorhexidine based. I don't know what CHC based. Chlorhexidine based. We'll answer the questions later. Can make a note of that.
Yes.
Bleeding, flushing, hand hygiene, time constraint. Yeah. So those are the causes. We are talking about pitfalls. Yeah. Okay. That's fine. Thank you. Thank you so much for your inputs. Next, move on. Okay. So these are the surveillance and metrics you need to follow. Track CLABSI per 1,000 catheter days. We're not going in detail about calculating and all this. If you're more interested, then you need to either take our IPC course or join the ICN course. You need to monitor the bundle compliance. And whenever you're defining CLABSI or defining anything, please follow established guidelines like CDC or NCDC definitions, and share data transparently. Just because you want to show your ICU in a better light, don't say it is less than 1%. Okay, if you're not following any of the checklist, and if you're not following even this basic 5 things which we talked about, definitely the CLABSI rate is going to be high. Okay, at least around 2 to 5. So you need to be transparent and share your data so that others can learn. And more important is trends. So what it was for the last 3 months, whether it is going up or coming down or staying the same, that is very, very important. So these are some best practices for surveillance and monitoring the metrics. Next slide. So again, we keep telling this again and again, removing unnecessary lines, access daily, remove when no longer required, reduce manipulation. So if the line is blocked, don't try to manipulate and try and make it work. You can probably try it once, but don't try it too many times, but because more handling, more infection. And if there is any concerns, communicate to the care team. Next slide. So what do you document? You should record the insertion site and the condition of the line, that it's working, and you have flushed and tested it that is working, and what is the dressing date and the last flush time. Any concerns or escalations probably should be marked in red, written in red, and you could probably use standard central venous line progress sheet also if you want. Next slide. Okay, again, I wanted to emphasize on the education. So the education is very, very central to prevention of CLABSI. People need to understand first, as I know, if you would listen in the first part of our webinar, we said one of the learning objectives is to make you commit to zero CLABSI occurrence in your hospital. And how we can get that zero CLABSI is again by following these 5 steps. But you know how difficult it is to practice this, simple things. And the best way to do it is education. So one is ownership. Teach the why each of these things are important. So if you say don't just put hand rub, you do a surgical hands scrub, you should tell them why you're doing it. It is because that this is a sterile procedure and you need to treat it as if you are doing it in theater. Okay, structured training. So you don't need to do a class for a long time, because central line education, the things involved with it will probably take about 10 to 15 minutes, but structure it well, have a pre-test, post-test, track it, make sure that people actually understood them, and then simulation. So you can use simulation to boost confidence. Keep on reinforcing it. Probably put a poster. You can give frequent alerts in the mobile phone. So all these things reinforces what you're told. And get everybody together. Don't just train the nurses in one class, doctors in one class. Get everybody so that we work as a team. So this sort of education, teaching the why, structured training, simulation, reinforcement, all of them are very, very important. Next slide, please.
So this is another question.
Yeah.
Yeah. So this question is about why is it important to scrub the hub before accessing a central line? So you have to tell me out of these 4 options, which is you are considering as important to scrub the hub before accessing the central line.
So this is the why. No, this is the why.
This is the why. Yes. So you can drop your answers in the chat box.
Everybody is answering C.
C. Okay. C.
It's going so fast I can't read it.
C.
Okay, I wanted to add one point there. I ask one more question.
Okay.
Why are you saying 15 seconds? I want to know the why. Why 15 seconds? Why not 5 seconds?
You're asking me or to the participants?
I'm asking the participants. You know the answer, right?
Yes.
So why? Because I'm always in hurry. I just want to do 5 seconds. Why are you telling me to do 15 seconds or 30 strokes?
Okay.
Why?
Okay. I think to reduce the risk of bloodstream infection, because act will happen. Prasanna Lasser have said because the act will happen in the 15 second.
Act? What is that?
Act, I think action.
Action?
Yeah.
Making it dry?
To make it.
Yeah, that's another important point. Chlorhexidine should dry before you actually for it to be very effective. Thank you so much, Saring, for bringing that up. But I'm asking why 5 seconds? Why 15 seconds and why not 10 seconds? Why not 20 seconds?
Mona Ghosh have answered as contact time.
Fantastic. Who's that? Yeah. Pratpati, you have hit the nail on the spot. Congratulations to you.
Yeah.
Okay. So there was a study where they cleaned these hub with alcohol for varying seconds. They found if you do it for 5 seconds, still the bugs were there. 10 seconds, very few. But 15 seconds onwards, there was not even a single bacteria spore on that hub. So this is the reason why it is done for 15 seconds. Now you understand why it is so important.
Yes.
Okay, so you need to tell the why. Don't just tell, do 15 seconds. If somebody asks why, don't question me. I am telling you, do 15 seconds. So when you turn your back, they won't do it. Right? That's what is happening. So you explain to them why, then they will themselves do it on their own. So very important too. So this is just an example for you to understand in education why the why is important. Yeah, next move on.
Yes. So here is like from knowledge to action.
Yeah,
So
you can take over and do this
yes,
session. Yeah.
yes. So we'll be
Yeah,
looking
thank
into
you.
the success stories and your next step. Thank you, sir. So these are the Indian success stories. As sir have explained earlier about Pranav's checklist. Based on that checklist, no, in our Indian hospital where they have implemented that as a quality improvement project, they have seen the drastic decline of report of CLABSI cases. Like 89% of reduction of cases have been done in their hospital, and also in the ICU the rate from 3.1 to 0.4 percentage out of 1000 catheter days have been done. So this is based on the Pranavas checklist, as sir have explained already. Like what the Pranavas was focusing on, only about 5 things. One is about like hand hygiene, second is about like maximum barrier precautions, and third on chlorhexidine hand no skin preparation, and optimal site selection, like making the femorals the least, and fifth thing is about daily review of line necessity. So depending on only the 5 components, this has been done. And the key to success, actually, it is the staff engagement. It comes because only of the training, as sir was mentioning about, not just the training specify based on asking questions why, and frequent bundle audits must be done, and also leadership support is strongly recommended for such reduction in healthcare associated infection. To implement any good practice, the leadership support is very necessary in the healthcare management. So when it comes to leadership and culture change, 5 things are there. One is aim for zero CLABSI. Always whenever you do some no when you wanted to do some quality improvement in your hospital sector, we used to focus on reducing from the number of existing cases to this number. Actually, aim for zero, aim for complete elimination of the case. It is not just about reduction, elimination. When you aim for elimination, actually you will achieve here the zero CLABSI, the total cultural commitment. And then second thing, you have to set goals. So set goal is about you're going to eliminate, not reduction of the cases. So you have to measure the progress. You implement the audit checklist, and you implement the bundle has to be followed by all the units. Wherever the central line is there, you have made that strict protocol, and it is continuously audit, and then you have to measure the progress where we are. So how many existing cases, and now after strict adherence to the protocol, where we are now. And then you have to recognize and reward the complaints. That is another important thing. So why? Because when you aim for some elimination, actually one of the unit have achieved the success rate in 1 month of time, 2 months of time, then you have to recognize them, you have to award them, which motivate other department to equally strive for it. And fourth thing, empower all team members to speak up. So whenever there is a challenge in following certain guidelines, in following certain protocols, you can have to give them privilege to talk in the meeting, so that you can give them the solution to resolve that and to bring a culture change. Fifth thing, lead by example. Who has to start all these things? Who has to start this culture change? We have to start, you have to start in your organization, and being an example, you have to show to the other organization how we have done. That's how the hospital where we were sharing about the Indian hospital, 2 examples, they have led by example. That is why that have come into the presentation. So this is about the success story in one of the district hospital in ICU in India. So what's the baseline CLABSI rate? It was like 6.5 rate of cases out of 1000 catheter days. So what interventions they have done to resolve this? They did daily audits of the checklist what they were using, and they have, and also daily audits on the nursing practices how they were following. Example, based on the Pranavas checklist, or based on the care bundle, whether they are following all the steps included in that. So based on that, daily audit. And the second thing, IPC nurse-led education. The education will be done interdepartmental, and also the major education focusing in all the environments will be done by the IPC nurse, infection prevention control nurse. And third thing, visual reminders at the bedside. You should keep on giving them the reminders. We have the high amount of rate has been reported in our hospital. Our aim is to reduce, no, our aim is to eliminate those cases. That has to be in all your visual reminders at the bedside. And also visual reminders at the bedside is about like all the best practice and good practice what you're going to follow. For the central line, hub care and hand hygiene, all the visual reminders, all 5 steps can be made as a laminated board, and you can keep on the bedside where you're doing that practice. So it keeps us, it acts as a reminder to make ourselves to follow all the steps without leaving anything. And also as an outcome in the district hospital, what has happened is like a tremendous, it is almost the CLABSI cases have come down like from 6.5 to 1.1 out of 1,000 in 6 months of time. This is the success story of the Indian hospital. To summarize with your path to zero CLABSI. So you should know, and you should know how to use the bundle. Actually, you should not, usually Dr. Pari used to say, do not use any checklist as tick list. You should know religiously you have to follow the guidelines, what is mentioned in the bundle. You have to religiously follow all these steps. You have to use as a checklist, not as a tick list. And then you have to teach based on why concept, why behind each step, why you're doing all these changes. If you are saying you have to scrub the hub, you have to say why. So as of sir have given a lot of examples why we have to do all those things. So that's how. And third thing, when you're auditing, you have to track the metrics, where you're standing, know how many cases have reported, and after 1 month of time, do we have any decline of cases, number of cases reported in CLABSI. You have to track the metrics and also equally share that results with all your healthcare providers who are involved in that project. And also empower the infection prevention control team and equally the frontline staff. And believe the zero is achievable. It is not achievable. It is not like you cannot achieve, you can only reduce. It is actually, there are 100% of possibility to eliminate the number of cases reported in the hospital. So for this presentation, the key resources and guidelines have been taken from CDC, CLABSI prevention guideline. This is all for your reference from where we have taken, the resources, and from the WHO IPC core components and NCDC India, HII surveillance manual, and Pronovist, and also from the NABH IPC toolkit. You can also take a snapshot of this to know detail more about all these guidelines. You can go through it. So if you have any question and answer, you can raise your hand. We will give access to talk directly in this webinar, and also you can drop your questions in the Q&A portal. Thank you so much, sir.
Thank you. That was an excellent summarization. Thank you so much, Stella.
Thank you, sir. So, in the Q&A, there was the first question which was asked is like, I think
the link has been shared. Please announce that as well.
Yeah, okay. Feedback link. Yes, feedback link have been shared in the chat box. This feedback link is for this particular webinar. So, your certificate of participation will be given after filling this feedback form. Okay. Why I am stressing on that? Because you will be getting another link for the on-site airway management during that announcement. So that please know during this Q&A session, I request all the participants to click that form and fill the form, so that when we move on to the next link, you will not be having any confusions. So there was one question at the around 2:50, I think. I think it was beginning of the session. How to define the word prolonged use? How many days? I think this has been discussed, sir.
No, there is no definition for number of days for prolonged. When it is not necessary, it is prolonged.
Yes.
And that depends on individual patient and setting. So we cannot actually define the number of days.
Yes. And there is another question from Jesna. Repeated insertion is acceptable.
Yeah, it's the same. I mean, you need to have a protocol. How many insertions are you going to accept by a person? If I am going to do insertion and I'm not that experienced, right? You can't always have experienced people doing it. So I may have to just join the unit and I'm learning. So if I attempt twice, then I need to escalate.
Yes.
Okay, so you need to have escalation protocols for insertion. So that is, you decide in the hospital and you decide, what is the maximum number of insertions you're going to allow for anyone before they need to escalate. So if you do that, then the number of repeated insertions will come down.
And also, the name is not there. There is a question. No, there's a concern
I think
actually.
Jasna has asked few more questions, I think.
Yeah. Oh,
Chlorhexidine dressings, you are talking about chlorhexidine impregnated dressings. All these chemical impregnated dressings are to get more money out of your hospital, and it looks very fancy. But science, evidence has shown that it is no better than those without these chemicals impregnated. And if you remove them promptly, have good practices of changing the dressings, then the results are the same. So don't waste money. Fortunately, there are no sponsors in this free webinar, so I can talk, what the evidence says. So don't waste your money on these fancy dressings. Transparent dressings, I already said, it's a must.
yeah.
Yeah.
This is not a question, it's a kind of concern. Like in our hospital, we are using 2% chlorhexidine, but in sometime doctor advised betadine to dress the area of central line. Was it okay to use betadine? They're asking like that.
Yeah, doctors are always the problem. No, the science is very, very clear. Okay, compared to betadine and chlorhexidine has superior results in reducing the bacterial population in this flora. We don't say population, like bacterial flora in the skin. So you need to use chlorhexidine, and I know convincing these doctors may be difficult, but that's the answer.
And just now again, what are all the types of lines are considered as central line?
Types of lines: internal jugular, subclavian. So which are going central line. I mean, central line is again femoral also will come under central line. Right? These are all lines which directly empty into the IVC. If you want an anatomical explanation, any cannula which goes into a vein that directly empties into the IVC is a central line.
Okay.
And
Tessering Lamo have asked us something regarding the contact time of CHG solution. I think chlorhexidine solution contact.
Yeah, it's that we answered that, no? You have to allow it to dry. There's no time for that. So you paint the skin and give enough time for it to dry. Once it is dry, you can go ahead.
Okay. So that's all from the Q&A portal. Let me check on the chat box, sir.
One thing says feedback. What is it about feedback? Not opening.
Not copying, madam.
Copying.
You have to click and then you have to fill it.
You click on it, it will open another thing. Okay.
Okay.
When we have to change transplant dressing, sorry, I don't have experience in that. We probably can find out and put in the WhatsApp group, but I can't answer here.
Okay, I'll go from the reverse, sir, because a lot of things are there in between. I'm going from the reverse pattern. Like one question is there from Elizabeth Madam, asking like what education to be given to the patients getting discharged with central line.
You can reverse.
What? Sorry, I'm going from the time from 320.
Education. Yeah. Okay.
Yeah.
It's about the five steps. And the again, if you read that paper, you will understand that. Now, please download the Peter Pronos. It's given in much detail what education they give, because I only spoke about the 5 things, but to achieve the 5 things, he did a lot of other things. So education was one, and organizing a trolley where everything was available in one place. Otherwise, what used to happen? People run from one place to another. To get the catheter, they'll go to one place. To get the the tray, central line dressing tray, it will be in another place. So that also leads to more infection. So he organized a trolley which has everything in place close to where you are doing the central line insertion. So like that, he talks about several things. So it's not possible to cover all of that in this webinar, but read the paper. You can learn more. Yeah. Next question.
Yeah.
Can we attend the airway management workshop online? You're talking about next week? No, it's on site.
It's
You
on-site.
missed it, boss. Last week was the airway management master class,
Masterclass.
but we will be doing it in future. So we will keep in touch. We will announce you. I think this month is going to be oxygen, right?
Oxygen, sir.
Oxygen administration masterclass is this month. We will announce it. So this is the reason we are asking you to be part of the WhatsApp group. We will be announcing this, and you will be getting updates there. But airway management this month is on site. It's in Chennai. So people in Chennai, can attend, and already there are only 50 spots. Already, I think 40 has been taken up. There's
Yes.
only 10 spots. So if you're interested, please register soon. Otherwise, the next on-site workshop will be after 3 months
Yes.
in that particular venue. But we'll be doing more in other places. So if you want to do it next week, please act fast.
So in your mail, when our tech team is sending a mail, your certificates are coming to your mail, they're also sending the link for the WhatsApp. That's our WhatsApp group, official WhatsApp group. So you can join into the group so that as Sir mentioned, you can look into all our programs which is upcoming.
Yeah, quickly go through the questions.
Yes, sir.
Which is preferable, jugular or femoral? We already discussed that. Neck veins, as much as possible, avoid the femoral, and you are practicing that. That is fantastic.
Yeah.
And transparent dressing up
Dressing up
to
to
7
7
days
days.
as per CDC. Okay. Too many times.
So that is about links, sir, I think.
PIC lines also we didn't. PIC lines is also central line.
Yes.
You got to treat it like a central line. So insertion, follow the same 5 things. Okay, we talked about education. I think we are done most of it, right? Okay, fine.
Again, everybody is mentioning about betadine. So about betadine, sir have clearly explained during the webinar.
All right. If
Yeah.
there are no further questions, I'm going to leave now. Thank you so
Yes.
much again. I think there was very. We probably broken the record this webinar.
Yes.
Number
Yes.
of participants. Thank you all so much.